Clinical Consultation Network. As you know, we do this every week. We do it at 12:30 Central Time. We always have very excellent guests on here. And this week we've got Dr. Jim Casey. We're going to introduce him in just a moment, but we're so happy to have him here with us today. He works with the Tennessee Department of Corrections. He's a great guy, so we're really glad to have him here today. Before we get started, I felt a need for us to address something that happened last week. Actually, it happened during the time that we were on the Clinical Consultation Network. I didn't find out about it until afterward, but that's the shooting that occurred in Uvalde, Texas last week. And then as we all know, that about 10 days prior to that, there was a shooting in Buffalo, New York. I have been troubled by these things, and I would like for us to address that with just recognizing a moment of silence here on behalf of the victims of these terrible shootings, and to just ponder that for just a moment. So if you will, participate with me in a moment of silence related to those two shootings that have recently occurred, and actually all of the shootings that have occurred in the United States in these last years. Thank you for that. And I just want to say, I know there are a lot of varying opinions about what needs to be done about these types of situations that we face. The one thing that I will say about this is that we need to do something. We need to address these issues. We need not let them continue to linger on. So with that, I will move us on into our agenda for today. And our lovely producer, Babs Tierno, is getting that up. So we'll review what we've got upcoming on CCN. Today, of course, we've got Dr. Jim Casey. He's the Director of Behavioral Health Services at the Tennessee Department of Corrections. I've known him for quite some time. I'm very anxious to get into his presentation here shortly. We also have Mickey Tonis next week. He's a board certified behavior analyst. He works for the state of Tennessee. And so I'm very interested in what he may have to present next week. June 14th, very important topic, choking within our system. A lot of people, probably one of the leading causes of death among people within our system and for people with intellectual and developmental disabilities is choking. And so we're going to have a panel discussion among several experts who will be here to talk about choking and ways to prevent choking accidents and the needs of people who have swallowing problems. So tune in on June 14th for that. And then on June 21st, we have Brian Keller here from the Tennessee Council on Developmental Disabilities. And so he is going to talk to us about his efforts over there on the council. So that's our upcoming presentations. As I say, don't try to cherry pick. Join us for every one of these because they're all going to be great. And next slide. Okay, get smart. Now, I did not prepare this on PowerPoint today, but I do have an article that Jim provided me that I'm going to share with you if I can figure out how to do so. Give me just a moment. I believe that's it right there. All right, so this was about risk factors for suicide in prisons. So this is a huge issue within prisons. Rates of suicide among people in prison are elevated compared with people of similar age and sex who are living in the community. And so what we're talking about here is improving assessments, interventions to reduce suicide risk. And so they did a very complex analysis in this study, but suffice it to say that there are a number of risk factors for suicide within prisons. And in their main analyses, some of the strongest clinical factors associated with suicide were suicidal ideation during the current period in prison. So if a person was thinking about suicide at the time that they were in prison, that was a risk factor, as you might imagine. A history of attempted suicide was another big risk factor. And the current psychiatric diagnosis was another risk factor. So if they had a psychiatric diagnosis, that was going to increase their risk. All of those things make perfect sense. Institutional factors associated with suicide included occupation of a single cell. I assume we're talking about solitary confinement scenario. So that, as you can imagine, would have a big impact on a person's tendency to commit suicide. Having no social visits was another factor. So when you don't have any family who are there to support you or try to help you, then you're more likely to commit suicide. Then criminological factors include your remand status. So I assume that means like what you're talking about is how long the person may have to spend in prison. So how long they're remanded for, well, actually serving a life sentence would be that. Jim, you may be able to shed some light on that when you speak momentarily. Being convicted of a violent offense is also another factor. So their interpretation was that there were several modifiable risk factors here, such as psychiatric diagnosis, so people can get more treatment for that. Suicidal ideation can be treated also while a person is in prison. Single occupancy can be altered, associated, and then preventive intervention should target these risk factors and include improved access to evidence-based mental health care. Understanding other factors associated with suicide might improve risk stratification and resource allocation of prison services. So, Jim, I hope you'll be able to shed a little bit of light on this entire article when you speak in a moment, but it does underscore how really important it is to be able to address concerns of mental health concerns of people who are in prison. So thank you so much for sharing that article. With that, I will turn the screen back over to Babs Tierno, and she is going to introduce today's guest, Dr. Jim Casey. And by the way, while she's getting that up, if you have a guess about what's different about my display, please go ahead and put that in.
All right, I'm having a little bit of technical difficulty with it's popping up on the screen I do not intend it to be on. So give me 1 second. There.
Technological problems. While you're doing that, I will just go ahead and reveal what's different about my backdrop, because you remember a few weeks ago, Babs, when I went to the charity auction for the Autism Tennessee, one of the things I bought while I was there was two tickets to the Van Gogh experience.
That's
Has
right.
anybody Van Gogh experience?
I haven't.
It's quite amazing. And I learned a lot about Vincent Van Gogh that I did not know before. So it was quite interesting, but I did get a souvenir while I was there. This is a dog bowl. So when you're traveling, you can open this up and feed your dog in this. I tell you, they come up with anything these days. I purchased this because it was the cheapest trinket I could buy there. But I also do have a dog that I have occasionally had trouble having a vessel to give him water in when I'm out and about with him. So this will come in handy. But it was quite an interesting display that they had there. I do highly recommend it to people so that you can learn a little bit more about the life and art of Vincent Van Gogh.
All right, well, my technical difficulties continue. So I am going to read my intro for Dr. Casey. So Dr. Casey.
Time there, Babs.
is a licensed psychologist who has served as the Director of Behavioral Health Services for Tennessee Department of Corrections since 2017. Dr. Casey has worked in the criminal justice population for over 16 years in numerous clinical roles. He has served in various administration and clinical roles within the court system, DC-4, I don't know what that is, and several treatment facilities. Dr. Casey has a broad array of rich clinical experiences, including co-occurring disorders, substance abuse treatment, psychological testing, private clinical practice, neuropsychological testing, and general psychological practice. Dr. Casey specializes in treating, assessing impaired professionals, substance abuse treatment, and has been deemed an expert witness for substance abuse disorders treatment for the state of Tennessee and the federal court system. So we want to welcome you, Dr. Casey.
Yeah, I just want to say, I met Dr. Casey, I think probably 10 or 15 years ago. I don't know. It's been quite a long time that we've known one another. So I'm really glad to have you on here today to talk to us about your work in the Tennessee prison system.
Yeah, I think you and I met each other sometime around 2007, 2008, right around that time frame. Yeah, so we've known each other since then. So thank you all for inviting me. I much appreciate it. Anytime I get the opportunity to talk about, Department of Correction and some of the operations we have going on, I always like to take the opportunity just so people can see what we're doing, so we can kind of share some of the challenges. And again, I think it's a good, because it was brand new to me before I came on board, but it's been a great experience. So let me go ahead and get my screen shared up here real quick.
Dr. Casey, I don't want you to forget about sharing that interesting fact about yourself, because I have been looking for this, ever since we.
Fact. Let's see. What would be a good, interesting fact about myself? Well, let's see. I have black belts in 2 different disciplines. So I was an All-American wrestler, in high school and through the Army, and then when I got out of school, I couldn't find any wrestling, so I got into judo and jiu-jitsu, and I have a black belt in both of them, and I've been
Okay. I had no idea you were into wrestling either, because I was a wrestler in high school. I never made it to college level, but that's fantastic. That was a very interesting fact. Thank you for sharing that.
Yeah, thank you. We'll have to wrestle sometime.
No, I don't think. Not anymore. Not anymore.
So can you guys see my screen all right? All right, great. Well, I'm going to go ahead and get going then. So as you see, it's managing behavioral health in the Department of Correction, and you'll see some of the challenges that we have. So the first thing I just showed right here is just a brief map to kind of show you some of the where our prisons are across the state. Some of the other ones you will see over there will be the district offices or the community supervision offices, where they also dispense, more supervision services for folks getting out of prison or trying to keep them out of prison. So as you see, our behavioral health services in 2015, what we did is the state of Tennessee decided that we were going to consolidate and combine mental health and substance use treatment into one contract. Previously, what they had done is they did everything separately. So just over time, they realized that behavioral health and substance use and mental health belong together. So they went ahead and did that. We also had in 2016 that we executed a 3-year contract that was $18.5 million annually. We saved some money doing it, but basically what they do is that we have a vendor, a third-party provider that provides all the mental health services within inside of our prisons and outside of our system. We also do the same thing with our medical vendor and providers, and just coincidentally, this most recent contract, the vendor is Centurion. They have both contracts. They want them independently, so we do that. It seems to work a little bit better, but again, it's what we do. And as you can see, our mission is to reduce the effects of serious mental illness, try to get somebody stabilized, maximize their skill sets while they're in the prison, and to get them prepared to enter into society again. I didn't put it up here, but what we also know is 95% of the people that are in our prisons right now will be returning to the community. So what are you going to do when those 95% of those folks get out? What have they done for the last 5 to 15 to 20 years? Are they prepared to get out? And that's essentially what we're going to be looking at. Another area that we deal with is sex offender treatment, which I could spend a whole nother topic just on that. And maybe I will come back to that at some point and discuss that. Mental illness and substance use are the main areas that we are challenged with and that are a struggle for us in the community. Some of the things that we've done, we have started developing multiple programs to both deal with substance use, to deal with the various mental health issues. And again, I'll explain these as we go through here. When I talk about supporting living units and recovery services, I'll talk about it on the next page as it comes. So some of the evidence-based program, and that was real big for the Public Safety Act of 2016, is we had to make sure that all of our programs were evidence-based in order to treat and meet the needs of folks. Now, I think this was a big paradigm shift for most people, definitely, I think, here in Tennessee. And the paradigm shift is, we have always heard that, prison is for rehabilitation and people going to prison get better. It wasn't. To keep it real, it was not that. Up until 2016, they would talk about rehabilitation, but the rehabilitation was really nothing. It was punishment. It was a consequence. So this was really something where real people are really starting to work into, what is evidence-based? What are some of the real treatments that we can do to help these folks? Because clearly, and I'll get into a couple stories. Clearly, our population of mental health and substance use is growing exponentially and has over the last really 5 years. And it's been doing over the last decade, but the last 5 years, it's really picked up dramatically. So what have we done? We've done SLUs. We've developed residential and various different levels of treatment for substance use. We're using telehealth, and that's something that's really exploded over the last 2 years. With COVID was something that really pushed us into that realm further. We had no choice. So it really pushed us to in sooner, and we were able to get that up to speed and to really be able to provide telehealth services, which is very important for some of our populations. We also did a behavioral health model to integrate mental health and substance use treatment in all the facilities. So essentially, 5 years ago, 7 years ago, 10 years ago, they maybe had somebody that was contracted to provide psychiatric work or to provide substance use work. Now, at every facility, I have a psychiatrist, I have APNs, advanced practice, nurse practitioners. I have substance use counselors, LADAC counselors, non-LADAC counselors that are working towards licensure, different master's levels, different psychologists at all facilities has some level of behavioral health and mental health. And again, that was something that was not here. So like I said before, as you saw that first model, or at least the contract was for about $12-15 million. I think the last contract we signed was somewhere in the vicinity of $110 million. So just to give you an idea of how quickly we've had to expand to keep up with the population and to keep up with the court systems. Sentencing.
Just a quick question on that. Have you been able to find adequate services with your contracts and get these positions filled for people that can provide those services you were talking
Sure.
about?
I mean, yeah, I think the staffing matrix that we have designed is exceptional. I think it really does cover. We're fully. I think it's a fully operational staff. However, I think like everybody, not just germane to us, but like everybody across the country, is facing shortages of staff. And in certain areas, certain specialized areas, you're seeing even more prominent. Trying to hire psychologists right now. I'm going to have to spend $150,000 or more if I want to get a psychologist and offer them only telehealth, that they can work from home and do telehealth. So that's a big one. Social workers are hard to find right now. LADAC, substance use counselors are a challenge to find. I'm doing pretty good with APNs. I'm doing pretty good, but nursing staff is just like, it's like a rotating. I get people in as quick as I get them in, they're going out the door. People are just jumping at, opportunities and again, prison is not easy work, and prison was easy to work. We had the advantage, I'd say up until about 5 years ago, we had the advantage in corrections in that we always paid more. We always had the opportunity to pay people more. 15 years ago, 18 years ago, I could get a job, in California for $100,000, That's not the case today. The cost has gone up and the shortages have gone up. So absolutely, that really truly impacts us and impacts everybody. I think in the prison where it impacts us the most is we don't get a chance to spend as much time with the folks as we want to, and that's from the correctional officers all the way down. Getting to know people and establish relationships, it's like therapy. It's the relationship that's really gonna be the driving factor in the force. So good question. Hopefully I didn't talk too much on that.
Well, the only reason I asked is because we're experiencing those problems in the IDD system as well. And, you know, it's a pervasive problem that we're all dealing with out there. I was just trying to seek some verification if you were doing the same thing.
Yeah. I mean, to the point where we've had to get pretty crazy outside the box. So we have something, and I'll just go real quick because I think it's a very important point. We have something where folks go on suicide watch and we have to have people watch them. Well, of course, that takes a full staff to do that. So what we've done is we have now trained inmate observers, peers that are going in, and we have them sit on the doors and report every 15 minutes. And again, it gives us an extra set of eyes and frees up some. I know it sounds crazy, but it's much more effective and cost effective as well. But we've had to do that. We have all of us, including myself, we went and got trained. So I essentially got commissioned without the weapon to be a correctional officer. And we are now going into the facilities and working critical posts on the weekends, after hours. I mean, and we're opening it up to retired law enforcement, retired state employees, retired military, trying to bring people in to cover what we can do. So, yeah, I mean, these are all things that we've never seen before. So trying to think outside the box. So, you know, it's a challenge, and yeah.
Those are some creative solutions to that. That is some we'll take to heart.
Yeah. I mean, it's like I said, it's everybody in the central office now has potential of working the prisons. Now they make it worth your while. They pay you pretty good money. The incentives are pretty good. So yeah, I'd definitely take a look at it. That would be something that benefits you. Now on to the next, to really kind of take a little bit deeper dive into our system. And the reason I'm kind of going kind of broad is I want to give you an understanding of how complex the system, how the system works. I could talk to you about just suicide. I could talk to you just about substance use, but without understanding the system, it really did. Without the context, it would be lost, I believe. So as you see, we have 14 prisons statewide. 4 of them are private prisons. The other 10, we operate fully. Our census with all the prisons was 19,000. Normally we're up there around 22, 23,000, but we've dipped over the pandemic and we're just starting to move that back up. And of course, we can't be, pumping up certain prisons if we don't have the staff. So that's actually also controlling that. Now, as you look at our mental health population, we have about 8,700 individuals that are on the caseload. These are individuals that either take a minimum of medication and have a low level mental health issue, and then it goes all the way up to folks that need to be in secure facility or in secure setting. So as you look at that, 45% of our population is considered on the mental health caseload. 45%. Clearly much higher than the population. What I always try to tell folks is what you see in prison is a microcosm of the bigger picture. So if on the outside in the general population, we're dealing with overdose, we're going to be dealing with overdose times 10. If you're on the outside, they're dealing with a mental health issue that has to do with suicide. We're going to see that times 10 inside the prison. Whatever problem that is on the outside, we are going to get that problem magnified because we're getting the top layer right off the population, and so we're taking that population. And the interesting thing about this, and you'll see the numbers that will fill in here in a moment, but I was talking to the legislature and the criminal justice and the finance folks across the street, and it dawned on me and it dawned on them right about the same time when I was going down and I was explaining to them how many people I have on the case, on our mental health caseload. How many beds we have to treat folks, in terms of mental health, severe mental health. How many beds we have to treat substance use. When I got done, saying that, he stopped me and he goes, almost like he didn't believe. He's like, so you're telling me, he goes that the Department of Correction has more beds across the state to treat mental health and substance use than we do in the community. And I looked at the numbers. I'm like, yes, I guess we do. We are the largest provider of mental health and substance use across the state.
And Jim, just a quick question on that. Has that changed any over the years, or has it remained relatively stable?
No, it absolutely has changed dramatically. And I can show you, like, I go back to 2018 roughly, and we're at about 30% of our population was on the mental health K-loads. Again, most of it's going to be, the garden variety, the mild, they're taking an antidepressant, they're taking anti-anxiety, but they're functioning. We're seeing more severe mental illness. So the sheer numbers, but also the severity of the mental illness is greater. I'm seeing more people that are having psychotic breaks, more people that are having thought disorders, or the big guns of mental illness. So that also is challenging in itself. So as you can see right there, the way we talk about it is we talk about our mental health and levels of care. And our levels of care that we're going to look at are 2 to 4. 2 being, again, garden variety. As it goes up in number, it goes up in intensity and in the inability to basically take care of themselves inside the prison setting. So as you see, we also get 55 to 60% of men entering prison self-identify as having a substance use disorder. 70% of the women identify as having a substance use disorder. And then 70% of the caseload is receiving a psychotropic medication. All right. One thing I also want to say here is we say that 55 to and 70% of the women and the folks are saying that they have a substance use issue. I would estimate that about 85% of our population inside the prison have some issue with substance use, from mild all the way up to the most severe you've ever seen. So, and then about 46, I think I did the math, about 46 to 48% would also fall into the category of having a co-occurring issue. So that kind of gives you the lay of the land of what we're seeing and what we have coming into our system. When we talk about our levels 3s and 4s, remember, as we go up in number, these are our more severe folks. These are folks that either their mental illness or their medication or their treatment for their mental illness will not allow them to to function or to be able to function inside the prison system. So we put them in a self-contained area called a supportive living unit. They're usually smaller units. They go up to 60. Some of them get up to pretty large, but the larger they get, they're harder to run. And that's where folks live, and they get just more self-contained care. And again, I think it's pretty much what I just discussed. It's a structured therapeutic environment. It's for level 3s and 4s. It covers a wide array, basically whatever we need to do to help try to cover stuff. Could be medication, could be group therapy, could be a behavioral management plan. It could be, strictly, incentive based, kind of a program to build on behavior. So a lot of different things we can do, and we try to do whatever we can to meet the needs of the individual. And here's this question that you're kind of answering in a more kind of a visual representation, where as you see here was our mental health caseload across the state when it went from 32 to 36, and you can see it just steadily keeps going. There was times during, yeah.
So we're just talking going back to 2018, and there's been a huge increase. So that's I thought maybe we were talking about a longer time frame, but it's just been relatively recent, this increase.
Yeah, I mean, and I guess I could probably go back and look even further back. And again, you got to look at, about 10 years ago or so, maybe less than that, 8 years ago, we started getting better at looking at mental health inside the system. Again, before the prison system said, "Oh, we're here for rehabilitation." No, it wasn't. That's that's a crock. It never was. Now we're looking at it from a rehabilitation perspective. But up until this last 4 or 5 years, that's not the case. So yeah, I think that's part of it. And then so we're just better at tracking it and looking at it now. But yes, we are seeing more and more mentally ill people hitting our system. Here's an LC1, and basically it just kind of talks about 1. If 1 means there's nothing. 5, if somebody has a moment of a mental health crisis, it could be a transient. They could go on and go off. It could be a bereavement issue, could be a medication issue, could be a substance use issue. But that's essentially what it is. And then you see the 2s, 3s, and 4s. which I always already talked about at length. Now, in terms of substance use services, so as you see, that's probably one of the largest problems that we have going besides the criminality that we have going inside of our prisons is substance use. So what we did is we have about 5-6 years ago, we developed a thorough substance use program across the system. So as you see, we have 13 intensive residential addiction programs. We have 14 outpatient. We have aftercare at every single facility. Basically, it'd be like a self-help group or AA or NA or something along those lines. Something we've started and it kind of got stalled during the pandemic, but we're back doing it again, is certified peer recovery specialist. It was something that they use in the community with the Department of Mental Health Substance Use Services. And we partnered with them, and we basically get our folks, our inmates, the ones that are sober for 2 years, they're doing well, to get certified, and they can get paid about $1, an hour, which is the highest we have in the prisons. And then it's also transferable to a job out in the community as well.
So this actually peers within the prison system.
Absolutely. Sometimes they'll hold some of these the peer-to-peer meetings, like a 12-step meeting or a family reunification or some type of support, that they can help out. Sometimes they're going to listen to inmates way better than they listen to us. And so you really take advantage of it. And that's something that I've been focused on since I've been here is, trying to maximize that as much as possible. We only have so much resources, so let's maximize them the best of our potential.
Yeah, that's right. And if you think about it, culturally speaking, they're living within the culture of a prison, and
they know everything.
Cultural peer.
Like I tell you, like I said, like when I used to put nurses or officers on the door for the suicide watch, and they have to watch them every hour. They sit there outside the door and watch them direct observation. When I put my inmates on the door, they do a 10 times better job. The notes are better. The observations are better. They are consistent with it. So it's just, it's interesting, as you watch it, how effective it can be to use the peers. Absolutely valuable. And we use it right now for substance use. I'm also in the process right now of expanding that and using it inside of our SLUs and using it with our mental health folks. And then also potentially using it inside of our restrictive housing units. And I'll explain that a little bit further down the road. That'll make sense why I'm talking about that. So essentially that's our substance use. And like I said, we have it all across the state. I have 1,600 beds that are available for substance use right now. So at any given time, I have 1,600 people that are getting anywhere from ASAM level 0.5 all the way up to ASAM level 3.1, which is inpatient residential, intensive outpatient, and then intervention. So again, I think that's one of the things I think we do a great job. And again, clearly we will never be able to do enough. It's never ending. I get calls all the time. I usually get calls from the warden all the time, telling me, you got to keep people from overdose. And I'm like, great, I can do that. If you can help me keep the drugs out of the prisons, we can work together. That'll be great. Right. Because that's the thing is, I got, what do we say? Roughly 20,000 people. I can't watch these people and hold their hands every single second. So, how we're going to do that is hopefully, be able to, create enough connectedness and getting to know them and getting them in an environment so they know where to go if they're struggling. And then keep drugs out of prison. I mean, do the best we can to keep them out, which is next to impossible. So some of the things we've started, like I said, we have specialized co-occurring programs. We started a specialized opioid program. It's all for opioids. We have 2 veterans intensive inpatient programs for substance use. We started withdrawal management, where we've added MAT into our prisons, not fully across the whole system, but this is the beginning of it, where we first started it. Now we got it in. Now, how are we going to expand it, and what does that look like? So essentially, that's what we're looking at here, and I've already talked about that. As you see, just goes in detail about it. We use the equivalent of ASAM level of care, which is 9 to 12 months, of treatment for inpatient and 150 hours for intensive outpatient. Again, just kind of shows you the drug screens. As you can see down here, we started off at 2870, went to 31, 37, 46, 55. There is no, I'm telling you, there is a correlation. And again, I don't have the data for it. If anybody's a researcher and is interested in doing some research, contact me and we'll take a look at it. But I think there is a correlation with the drug use and the drug system, what's going on with the drugs and the suicides. I think there's a connection with the individuals that are doing it, but I also think that seeing the increase of the mental illness is related to the addiction as well. I just think it's been so broad and so vast.
So the point being, Jim, we're on pace for a much worse year in 2022.
100%.
With 300 already through April.
With everything. And again, I'm going to get to it. So what we also have is we use FSWs. We call them forensic social workers. They're master, not all LCSWs because we can't afford them. We only pay $30,000 or $32,000, so we try to get master level folks that are working on licensure, and we get them to work across the 95 counties. They provide groups. They basically do a really extensive clinical case management, get people into programs, get people connected, deal with crisis interventions. So they do a great job. And as you look down here to the bottom, the FSWs get about 15,000 referrals a year. So it's pretty hefty. We use something called we use community providers. We use Day Reporting Center, which is an alternative. We have 6 of them across the state. It's like a 2-year program that runs intensive outpatient, treatment as well as job, kind of support throughout. And then we have something called the Community Treatment Collaborative, where we spend like about $4.4 million for the state of Tennessee Department of Mental Health Substance Use Services to help put our folks into treatment and to come up with a pricing system. So that's essentially how we do that. And it works. 57 providers. Basically, we get over 2,000 people treated each year. Again, there's Day Reporting. I talked about it. Again, it's a 2-year program. I won't go into it too deeply. Some of the initiatives that we're dealing with is co-occurring programs. We're still doing that. This is important. Certified peer recovery. We've hired 2 trainers that are fully trained, so now I can just constantly pump them out. We do something. This is very important. Is training the staff to be prepared to have the skills to know how to talk, to know how to de-escalate, to understand what to look at, how to look at somebody with a drug system, drug distress, or somebody in a mental health distress, how to best deal with those things. So anything we can do, either the behavioral health certification, crisis intervention, we're constantly doing stuff with suicide prevention. And another thing to add, another layer to it is our correction officers, our correction staff are 4 times more likely to commit suicide than the average peer, than the average professional. So it is also a heightened, job stressors for our corrections officers. So at the same time, I'm asking, we're tasked at trying to deal with these suicidal folks, these mental health folks of our population. At the same time, the main people that I'm having watch them 85% of the time are also at increased risk.
Yeah. So you got to take care of your staff to be able to take care of the prisoners.
Yep. And the pandemic really pushed that to the brink. And I'm sure everybody, all the professionals, have had to deal with the extra added stress of the pandemic. I mean, our doctors, if you look at our physicians, they increased, suicidality by 50% during this time frame. We can't keep some of those high level doctors and nurses because they got so burnt during the pandemic that we're completely rebooting. That doesn't happen usually. We turn over, those positions don't turn over that quickly, right. But because of the mental health strain, it's really changed everything. So now to bring up the 2 biggest challenges that I'm facing. We always have challenges, always have issues going on, but the 2 biggest things that cause me to lose sleep on the regular basis are increased suicide behavior. I say increased suicide behavior, but really I'm talking about is completed suicides. We have about anywhere from, let's say, about 60 to 70 people, anywhere from 30 to 60 people on suicide watch every day. In that, we have about, if I go over the last, from 2017 to 2021, these are the suicides. Before 2017, we averaged 3.1 a year. suicide deaths. For something started changing in 2017. We went to 7, then 8, then 10, and 12, and 13. Right now we have 4 this year. But again, I realize that doesn't matter because we go through the summer. The summer is going to be pretty tough, and the holiday season is also very difficult for our folks. Now, 13 is a high number. Even if you look at the numbers across, and what they like to break it down is per capita per 100,000. And I bet you this is well up over 45. It's probably up over 50 per 100,000. That is a lot. That's not acceptable. We have worked with various entities across the country. We've added things. We get a little bit of help, but then it comes right back to it. And that's kind of what we're seeing is people are getting better for a year. They're going with an expert consultant, getting better for a year, and then it comes right back. So clearly we're doing as much as we can, but I'm going to put it out there. Prison, and I'm going to say it, and I don't care what anybody says, prison is not conducive for mental illness. It's not conducive for providing high-level treatment. Period.
In fact, it's oppressive to be in prison.
Absolutely. If you were to come, and this happens all the time, again, may not be the most appropriate thing to say, but if I go to somebody and I'm sitting there at year 18, I'm talking to a 30-something-year-old guy, I'm there at year 18, he comes in and talks to me like, hey, I'm feeling really bad. I don't feel good about life. Well, tell me what's going on. Well, I just found out that I'm going to have to serve out the rest of my 30-year sentence. So I got another, 15 years to go. Nobody is coming to visit me in 14 years. Nobody writes me letters anymore. I'm hooked on drugs and I don't have any money and the gangs are chasing me down because I got drug debts. You know what? I'd be like, yeah, I'd be depressed too. Absolutely. I would want to do drugs and I'd probably be looking for a hopelessness and a worthlessness way out.
Yeah, I fully understand what you're saying there. Yeah, it's a huge stressor. It bothers me sometimes the length of some of these sentences that people have to have as well, because it does take some of the focus off of the treatment that you're trying to do and trying to help rehabilitate people.
And again, and I'm going to keep it real. Again, I just keep it being very honest about it. Is Tennessee does not do a very good job in that area compared to our other peers across the country. We're working on it. We're trying to do better. And what I mean by that is we've added drug programs. We've added all sorts of programs for the probation and parole to take a look at it and to take it in consideration when they do parole. Well, guess what? We're like dead last in paroling people. It doesn't matter what they have. So that's one of the things that our governor office is pushing and saying, hey, we got to work on this. Because you're right. If we can get these people treatment and get them out or maximize alternatives to treatment. So alternatives to incarceration. So get the DC4, the Davidson County drug courts, any of the drug courts, the mental health courts, maximize those. You're going to save money. You're going to get more efficacy in treatment, and you're going to not disrupt that person's life. Prison is not a place to be. There is nothing good or fun about prison, period. And I've taken this stance, and I've taken even a stronger position at it. Every year I work here, the stronger opinion I have about that. If I look at the two things, the highest things that are related to the suicidality is restrictive housing. When I say restrictive housing, that's the segregation that you're talking about, where an individual is locked down 22 to 23 hours a day. They only get out to go to the bathroom, take a shower, and walk in the yard and come right back. Number one thing. That's the number one thing. I would say about 80% of the folks. So that's the issue. Housing alone is when I put these people in restrictive housing, they go ahead and do that. We've added a whole bunch of things. So we don't have a lot of people that are suicidal that tell us and kill themselves. We have taken care of that problem. It's the ones that aren't telling us, that aren't on the mental health caseload, that are in segregation. Those are the ones that we're not having a good time getting to and trying to figure that out. So this is why I'm coming up with trying to put certified peer recovery specialists in the restricted housing units, 24 hours a day, and also have them doing recreational, like games, crossword puzzles, anything they can do to break up the monotony of sitting in their brains. Or also letting people know, hey, this guy's talking to himself, this guy's acting weird, this guy's acting sad. So again, trying to maximize the eyes that I can put on somebody. I say drug-related issues. when I look at a lot of folks, they're strung out on opiates, and it's very painful. They don't want to tell on anybody that they're using drugs, so they don't want to go to treatment. They also, what happens is these folks will get drug debts with the gangs, and then the gangs will. That's what I call suicide by intimidation. The gangs will extort them, will intimidate them, will try to extort the family, will threaten the family on the outside, and then they just get to a point they're like, I can't take it anymore, and I'm out. So those are probably the two biggest things that I think the drug use and restricted housing are the two biggest things that if I took care of that, I'd take care of 85 to 90% of the suicides in our system. Overdose is another huge issue. And the overdoses have increased over the past 3 years. As you can see, mostly related to fentanyl. And this has gone like wildfire over the last 5 years. I mean, can't keep up with it. It's going faster than lightning. If you look at the deaths in custody, right there in 2019 we had 4, in 2020 we had 13, and then it jumps to 47 in 2021. Now, don't worry about 2022 because we're too early right here. It takes about 6 months for me to get the toxicology screens back, so this is going to jump exponentially. It's not going back down. If anything, it's stabilizing or going higher. So 47 related deaths related to fentanyl. This is terrifying to me. This is
But that
frightening.
together with your suicide numbers, that's just remarkable.
Terrifying.
I mean,
It's terrifying because it's in everything. So if somebody, I mean, it's unbelievable. So fentanyl is in, you can get pills that look like anything now. It could look like aspirin. It could look like a benzo. But it is actually a pill that is stamped to look like that pill, but is actually fentanyl. They're all over the system. They take it, they're overdosing, they're dying, unless we get to them. The other thing that people are doing is I even have it in marijuana. You can't even smoke marijuana anymore without being laced in fentanyl. I've had it in cigarettes where people have, they roll their own cigarettes because it's cheaper. Well, those people are lacing the tobacco. So I've got Narcan everywhere to try to bring people back, and it's crazy. So as you look right here, and in May of 21, I just want to give you an idea. In May of 21, right, 2021, we had 27 Narcan events in 1 month. That's essentially, and that's what it was. It was 18. It was around that time frame, with about 5 deaths over that time frame. Now, starting in November of 21, we've had consistently 85, and I said to 103. That's wrong. It actually is up to 113 because it was last month. We just broke our record. So anywhere between 85 to 113 incidences where we had to use Narcan to bring somebody back to life. Think about that. And still, about 50 of them are dying. So think about that. I mean, that is frightening. That's terrifying.
Those are shocking numbers.
Yep. Yep. And how do I stop it? Guards bring it in. Visitation. People come in visitation, they bring it in. People drop stuff by drones over the top of the prison. I mean, anything you can think of, it comes through the mail. One of the things that people like to abuse is Suboxone. I know that's one of the things that people use as gold standard treatment. However, it's also the number one most abused drug in my system. So it's a double-edged sword for us. But that right there, you can get a high off of it. What they do is they melt it down. It comes in a very small, like very thin layer. They melt it down, melt it into a crayon, and then they take the crayon and they color stuff with like a coloring page, or they color a card and they send it in, and then they melt that down, and that's how they get it in the prisons. You get the size of a stamp. You put a size of a half of a stamp. That'll go for about $350 in our system. And that's just, and you can use one of it to get high, and the rest of it you can sell. So it's a high commodity. It's easy to get in, and we're not even coming close to stopping it. So it's terrifying. And again, we're working diligently to get withdrawal management, to get MAT in there. I'm in the process of trying to expand it so we can get people on MAT, maintenance. I'm not all for that. I think people, need to learn a balance of both. But at this point, it's about saving lives right now. Now it's not just about recovery; it's about life-saving measures as well as recovery. So now I'm definitely into it with inside this system to get MAT maintenance in our system. So I know I covered a lot. I'm sorry if I went too far, too long.
I think we've got tons of questions we want to try to cover in 5 minutes here.
And I apologize if I went too long.
And I'm going to let our audience ask the questions first through Babs. So Babs, do we have some questions over in the chat box?
Yeah, I want to start with one from Mary Elizabeth Wood. It says, are services/treatment modified in any way for inmates with IDD?
So yes, and unfortunately not well. And this is something that I'm extremely passionate about. It gets me really pissed off, and I'll let everybody else know about it. But it's a good thing because I should be, and as we all should be. So yes, we have folks that will come in, and unfortunately, by the time it hits us, so I have how many people would I have that have IDD in our system? Probably a good fair amount. Probably a good, I would say, 3 to 5% that are going to be on the intellectual lower piece. I think the other folks have been, with the developmental issues have been kind of, hopefully weeded out. However, they will hit my system where I have at any given time about 5 to 7 folks that I would consider on the moderate, IDD spectrum, and do not function well in our system. So there's we put them in our SLU. We come up with very specialized plans, but it doesn't matter what I do. It's noisy enough. You try to take somebody with an IDD and you put them in with cement and steel and noise and cold. Guess what you're going to get? I'm going to get decompensation and problems. I have a young lady right now, which is how Dr. Davis and I got back into this. Was I said, hey, we need help, and he came down. His team were taking a look at it, and we've had some meetings about it. And it doesn't matter what we do, this lady. She will be back. She'll be good for about 3 days, and she'll be back taking her clothes off, cover herself with feces, and bang her head up against the wall. And it's going to be a weekly thing or a bi-weekly thing that we have to have support. But what are we going to do? She should not be in that system, period. The courts have let her down. The courts have let the system down because we spend a lot of time. But how do I keep that young lady safe from herself? I can't. I can barely do it. She would be better off in a place that could really take care of her and keep her safe. We barely can keep her safe. And I have about 3 folks like that right now that are a challenge.
And Jim, you said moderate intellectual disability. So is it more or less, and I know you haven't done a study on this or anything or tested people, but so there'd be a lot more people with mild intellectual disability who are there, but they can with.
Oh, absolutely. I bet you if you went and you look at the intellectual function of our entire population, you're going to get in a very, very low average, and you're going to get a lot of people that easily jump off below 70 without a doubt. It goes hand in hand with this population.
I've got 2 more questions, and I don't know which order to do them in. One,
whatever you want.
How do we prevent that person from getting to your prison? So I guess that the person you were just discussing.
We tried. And I say we tried with Dr. Davis helped us out. Is it Trey King? He helped us. Is it Trey? Right? Not Trey King.
Yeah,
it was Trey.
Trey are great.
Yeah, Trey tried to help us out. So what we did specifically with this case is when I know something's going on, and these people actually were in when we first met, got out, and then came back, so they hit the revolving door. 2 things I think is one is we got to work better. And one piece we're missing is the courts. Bruce and our departments working together. We got that. I'm comfortable with that. What I'm not comfortable with is either the prosecutor's office, the public defender's office, the general court, the court system, because that's what we're missing, because that's where I would attach. The moment I found somebody or we knew somebody that was coming up and they were hitting our system or whatever, we should be alerted. Dr. Davis and I should be alerted. We should know. We should jump in there. What I would do is we make sure that we get a forensic evaluation. I know sometimes to stand trial, but even the competency to stand trial is not good enough. It's not sufficient because they may be able to stand trial and are competent, per legal terms, but just because they're competent to stand trial does not tell you how poorly and how inhumanitarian it is going to be for them living inside of a prison. Two different things.
That goes into the next question, so I'm glad I did them in this order. So the other question was, it's kind of more a statement. Not everyone with IDD is incompetent. Can you talk about how that works in a prison?
Absolutely. Like I said, we have, just like what we just said, is I have folks that are competent and most of these folks can make it through. It's the folks that really just can't get on with the daily living, or their daily living just so grossly takes a decompensation hit. And again, I mean, where I'll walk through a prison and I'll come walking through and I see a guy just sitting there on his bed and it's 9 o'clock in the morning. He's rocking back and forth with his shirt off and just his underwear, rocking back and forth. They can't get him out because he attacks everybody as soon as he opens up the door, and they have to use force and chemical weapons. And I come back and he's picking, the typical look. You know what I'm talking about? Where he's rocking. He's soothing himself and he's playing with this. He's playing with the with a little tag. I mean, I see the sensory. I see it all. I come back out 6 hours later. He's doing the exact same thing in the exact same spot. He's on medication. There's nothing you're going to do. That environment is what he's dealing with. And again, how do we deal with that? It's like, that's the extreme cases. Those extreme cases, we don't do very well. We put them in our infirmary. Our infirmary is still cement and it's still concrete and it's still steel. There's nothing padded. If somebody decides to jump off a second floor or even just, fall over from standing up, they're going to get stitches, or worse. So again, what I would like to see is our two departments and really our commissioners, really take it to the governor's office, really take it to the attorney general's office and say, listen, we got to really look at these people that are moderate to profound, really all of them. But these other people, we are absolutely doing a disservice to the state of Tennessee, anybody that has to take care of it, and the individuals have to suffer through it. And I say we do that and we, let it happen. What I'm doing now, I didn't tell Dr. Davis this, but what I've decided I'm going to do is there's something that we have medical furloughs when somebody has they have cancer or they have some type of terminal illness where you let them out, before they, so they have to serve the rest of their term. Well, we also have under a medical furlough, we can do a behavioral health furlough or a mental health furlough. So that one lady that we've been dealing with, she's, back at again, having issues. I'm going to have the site put in for a behavioral health furlough. It's probably not going to go anywhere, but I'm still going to make a deal out of it. So.
Well, keep trying, Jim. I tell you, this has been fascinating today. I just appreciate you coming on here so much to talk to us about these issues. I think they're things we all need to be thinking about and acting on going forward. I really appreciate you coming on today and talking to us about what I really love about you is your pragmatic approach to all these things too. I love to see somebody be pragmatic about offering mental health services and saying this is not just a pie in the sky thing, it's a practical issue. We've got to help these folks with this.
Yeah, and one of the things that I see is, and again, I think we've seen it over the years and in the politics and stuff is, we don't know we don't know all the answers. Nobody does. I mean, it's happening across the state. It's happening across the country. So you got to be willing to try things, and if it doesn't work, to tweak it and try something else. And keep on trying because, like I said, there is no playbook for some of this stuff. We've never seen this stuff before. So, you got to think outside the box and be willing to think outside the box and take those risks.
This has been fascinating. Thank you so much, Jim.
Thank you all.
And thank you, everybody else who's in our audience today. We really appreciate you being here. Of course, this is the Clinical Consultation Network. We do it every Tuesday at 12:30. Join us again next week when Mickey Tonis will be our presenter. Bye-bye.
Thank you all.